Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Avalada from Roots Community Health, reporting for the week of September 8th, 2025. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we're here to cut through the noise and bring you the latest information on health issues relevant to us all. After an update on COVID and respiratory illness status, and measles and some of the current goings on in health leadership, I will review some data on optimal booster vaccine timing for the COVID vaccine. First, starting off with an update on respiratory viruses and measles status. First, taking a look at respiratory viruses, and these are from specimens that are collected at laboratories all across the country. So this is tests that are done in a clinical setting for respiratory conditions or respiratory illnesses. And we can see that in the gray line, the rhinovirus enterovirus is continuing to make up the largest share of those tests, followed by SARS-CoV-2. And taking a look at COVID in the wastewater, we can see the black line there in the middle represents the average nationwide. And so it is moderate, but increasing on average nationwide. But we can see that each region looks very different. So the West and the South are both high, but the West looks like it might be coming down. So hopefully that means it has peaked and is coming down, but we'll just have to wait and see. The South continues to head up, it appears. And then looking at the Northeast and the Midwest, those are both considered low, but we'll just have to see which direction those are going to be going in. And when we look at COVID epidemic trends, and this is where we're looking at emergency department visits primarily to see if we have declining or increasing COVID infections. And what we can see is that in most of the West and the South, that appears to be declining. And in much of the North and Northeast, it is increasing. But remember, this doesn't mean that the dark purple ones have more cases than the green ones. It's just telling us about the direction that things are heading. And that makes sense based on what we just looked at in the wastewater. So for example, the teal color being the West, it's high, but coming down. And so that makes sense correlating to the map here that it's declining. But once again, that doesn't mean that things are low. In fact, we are seeing quite a bit of COVID on the West Coast and in the South, but it appears that it is declining. So that's good. And then in the North and Northeast, it is increasing. So we'll just have to see how it goes from there. And when we take a look at hospitalizations, we can see those are also nationwide continuing to increase. This varies a fair bit depending on the state. And so that's something that you can take a look at. The link for that is in the post, but on average, it is still increasing as of August 16th, 2025. And so we would expect deaths also to be kind of increasing behind it. And deaths the week ending August 16th were 230. And that's a little bit higher than it was the week before. But we're still doing much better in this area in terms of death, even though we're seeing a lot of SARS-CoV-2 in the wastewater, and even though we're seeing emergency department visits and hospitalizations. So at least this is an area in which we seem to be improving. And taking a quick look at measles. Measles cases continue to be coming in. We're now at 1,431 cases for the year for 2025. This is now more than 5 times what we saw for the entire year in 2024. So we're continuing to kind of break records as it relates to measles. This represents a 33-year high. 12% of these cases have led to hospitalization, and the vast majority, 86%, are associated with outbreaks. And we have had 3 deaths, including 2 in children. And speaking of children, I've been sharing for the last many weeks this slide, which shows the proportion of emergency department visits with diagnosed COVID-19 by age group. And this has been rather alarming because it is showing that the younger age groups were being seen in the emergency department for COVID at even a higher rate than our 75 and up age groups. But this visualization is actually no longer available on the webpage of the CDC's website. So this used to be something that was easy to access. But now when we go to that link, we get to this surveillance and data analytics page, which is a pretty simplified version of some of the data that we look at. So for example, this is showing the early indicators, which are tests, positivity, as well as emergency department visits. And it's kind of showing week over week, so you can compare to the weeks before, but very simplified. You can't get a breakdown by region or by age group. And so not quite as informative as the nuanced views that we've seen before. And same thing with hospitalizations and deaths. And then it is showing the death rate, which is what we also look at every week, but just it has some other ways to look at it. So I'll have time to get into more detail on and try to locate some of the things we've looked at before and see if it's still accessible. But I did want to share that they have updated the preliminary estimate of COVID-19 burden as of the end of August. And so I thought I would share that because I think it is helpful to remind us. So now this is showing us about 10 months. So from October 1st through August 30th of 2025. And what we're seeing is quite a significant burden from COVID-19. So somewhere between 12.7 to 19.1 million illnesses, 3 to 4.4 million outpatient visits. This is really significant. 350,000 to 510,000 COVID-19 hospitalizations. So this is quite a significant burden for that 10-month period. And then 39,000 to 58,000 COVID-19 deaths. So as I mentioned, I'll need to take a little more time to look around on the CDC website because things have been getting moved around and updated. And I want to see what reports can still be built or put together, even if they're not readily accessible like they were before. So more to come on that. And while the changes that I pointed out aren't necessarily an inherently bad thing, when they're coming at a time of serious concerns about agency leadership and credibility, let's just say the timing is not ideal. Also, when we're talking about losing a clear line of sight on how COVID is impacting children going to the emergency room with COVID at the same time that the recommendation for COVID vaccines in children is being severely limited, this is definitely raising eyebrows. So clearly there's quite a bit of chaos and confusion right now because the booster vaccines are finally becoming available, yet there's a definite hodgepodge across the country in terms of how or if they can be accessed. And this is also rapidly changing. So a few things I want to say about this. One is that states are definitely stepping up and stepping into the void being created by the lack of serious or scientific leadership from the federal government. Vaccines are being approached differently across the country. So for example, California, Oregon, and Washington recently formed the West Coast Health Alliance in an effort to create science-based public health guidelines in the wake of the gutting and destabilization of the CDC. Hawaii recently joined in. Their governor, who happens to be a physician, stressed the importance of being science and fact-based and remarked on the relative success that Hawaii has achieved in mitigating severe COVID outcomes. So this alliance will finalize their shared principles reportedly over the coming weeks and promises to ensure that public health policies are informed by scientists, clinicians, and public health leaders. And they will begin with immunization recommendations. A similar alliance seems to be in the works in the Northeast, and the states of New York and Massachusetts and New Mexico have each also created their own policies to preserve vaccine access. For example, New York declared a statewide disaster emergency to preserve COVID vaccine access. And Massachusetts is requiring health insurances to pay for the COVID vaccines that are vaccines that are recommended by the state. So not only those that are recommended by CDC. And in general, many of these states are looking to preserve the ability for pharmacists to administer vaccines without prescription. So building upon the structure and the assets that were built in the early pandemic years instead of throwing them out the window. But meanwhile, other states like Florida are actively working to undermine vaccine access, not only for COVID vaccines, but even for childhood vaccines. So definite disparities across the country in how this is being handled. The other thing I wanted to point out is that regardless of what state you're in, if you have any of the conditions on the very long list of conditions that put you at high risk of a bad outcome from COVID, then you are still eligible to receive the COVID vaccine if you're 6 months or older and have one of these underlying conditions. And remember, there's a whole host of conditions from mild behavioral health challenges to smoking, to asthma, obesity, diabetes. So if you're having to rely on a health condition in order to access the vaccine, I think that's scandalous because the evidence is very clear that the benefits outweigh the risks in all age groups, but this is where we are at this moment. And so if you have to lean on that, the list is quite extensive. And in addition to that, physicians are at liberty to prescribe or administer the vaccine off label. Now, pharmacists may not be able to do this, but physicians can. So if you are in a state that's really limiting things and you don't have an underlying condition or your child does not have an underlying condition that you can point to on that list, then it may be worth trying to locate a physician that is following the science, because if they're following the science, then they may be willing to prescribe off label. Although I will say that this particular climate is not particularly friendly. And so you may have science-based physicians that are just conservative and concerned about doing this, but it does not hurt to ask and or seek a new physician who is willing to follow the evidence and support you in that way. So this is all very chaotic and unfortunate, especially because this is happening at a time when the new formulation of the vaccine is actually available and being distributed. So here at Roots, we have already received our Pfizer vaccines. We're waiting on the others. So this is perhaps by design that this is happening simultaneously with the undermining of vaccine access, the gutting of the CDC, and confusion regarding coverage, because we know that we've heard from some of the people that are at the highest levels of health leadership. They have cited the low uptake as some kind of reason for changing guidelines, which we know is not consistent with science or any sort of evidence. But again, here we are, and in this moment where there's so much confusion and where there are many places that have been able to give the vaccine before that are now questioning whether they can, and people uncertain about coverage, we're concerned that uptake will be even lower and give more ammunition to that ridiculous argument, but also more importantly, reduce actual vaccine coverage across the population. So given all of this, given the moment we're in with all this chaos, I thought it might be helpful to ground us in some of the evidence around the additional COVID-19 vaccine doses. So specifically, we know that immunity or protection against COVID infection is complex. It's related to a number of different factors. This has evolved over the years that we have been dealing with SARS-CoV-2, but includes obviously prior vaccination, prior infection, your immune system, the immunity of the population, the variants that are circulating, among other things. We know that getting the repeat COVID vaccination or an annual vaccination or a booster or whatever term you may prefer reduces the risk of getting COVID. It reduces the risk of transmission, not as much as we would like, but it reduces it all the same. And it reduces the risk of bad outcomes. And we know that there have been efforts to time vaccine availability with flu vaccine availability, which is right around this time of year. But that hasn't always necessarily been backed with evidence around the best timing for the booster, but more the convenience or trying to create some kind of predictability and kind of logistics timed with the flu vaccination. But how should we actually be thinking about the optimal timing for COVID boosters? Because this is not flu. So this study published in Clinical Infectious Disease in their February 2025 issue set out to answer this question. So I like this study because their approach I thought was pretty unique. They really sought to address much of the complexity that I mentioned. And this is pretty difficult and kind of fluid, given that we've only been living with SARS-CoV-2 for the last 5.5 years. And although some patterns are kind of emerging, it's really not falling into particularly seasonal pattern the way that flu does. So this makes it a little bit more challenging, and we're not able to follow the methodology, strictly speaking, that we can follow for the flu. Instead, we've had surges at different times of year. We've also had new variants emerging at different points during the year. So it's a lot less straightforward than the flu. So for that reason, the authors here took a different approach to evaluating the best timing until we get to the point of having more historical data and maybe a more predictable pattern, and then we can get even more nuanced about this. But because there has been quite a lot of data collected over time across the world, really, the authors did have a fair bit of information to work with. So here they use a lot of geographic data and information, as well as what we know about antibody and reinfection probabilities, to develop a geographically informed approach to determining the optimum booster timing. So they basically quantify the probability of infections based on predictions of the incidence of COVID in many places across the globe. They looked at US to UK to Japan to China and more. And they basically modeled out the evolution of the virus. It gets pretty detailed and technical. So if you're interested, check out the link in the post. Then they estimated the probability of getting infected by using data on antibody levels for those who have been previously vaccinated and those who've been previously infected, and so on. Then they did a lot of calculations on the probability of being infected under these different scenarios. So their methods definitely are leaning on a lot of prior evidence around antibodies and around virus evolution and around probabilities of so-called breakthrough infections after boosters, including the clinical trials for the Pfizer boosters. They also reference some of the studies we've gone over on prior briefings that estimate that the annual booster reduces the probability of infection by about 67%. But what they then determine here in these analyses is that if you get the booster vaccination at different times, this is going to affect that 67%. It can be much better or it can be lower based on the different factors that they looked at. So based on when you get your booster vaccine, as well as the fluctuations of SARS-CoV-2 in the environment, this is going to contribute significantly to how effective that booster dose is. So in each of the geographic areas that they looked at, they actually were able to demonstrate an optimal date where boosting actually increases the protection 3, 4, or even 5 times compared to other times of the year. And the timing of these periods was different between New York versus, let's say, Sweden. So in New York City, a yearly vaccination on September 15th provides the lowest yearly probability of getting infected. And the least effective date in New York was January 24th. And then after January 24th, it gets increasingly more beneficial up to that optimal date again of September 15th. So if you're interested in other areas of the world, definitely take a look at this article, because you could find out, for example, that in Yamagata, Japan, the optimal date is in October. It's October 18th. Now, all of this is assuming not having had a recent COVID infection, because this recommendation of the optimal timing actually changes. So the optimal timing of the booster vaccine was significantly changed if there was an infection during that interval between the yearly optimal vaccine dates. And this gets a little detailed, so bear with me. So for example, in the New York example, if you got an infection anywhere between September and March, that basically has an effect similar to a booster vaccine in terms of the protection you would have after that. So therefore, the recommendation is to delay the booster shot. So for example, if you're one of the many people who was infected this past August, which is just before what the optimal time for the booster dose would have been, then your booster vaccine should be delayed. And these findings were similar in other geographies as well. And I'm going to give you a little bit more specifics in a moment. So it is thought that in the Northern Hemisphere, the fall is indeed the best timing for the annual COVID vaccine based on what we've experienced so far. But of course, things can still evolve and change. So I think a study like this might need to be repeated over time to see if it holds as some of the conditions change. There are also a number of limitations and things that the study did not contemplate. For example, the analyses were based on so-called typical healthy adult immune responses. But we know that if you look across a population, the immune status of individuals varies quite a lot. So if you're on certain medications, if you have certain illnesses, if you're pregnant, depending on your age, and so on and so forth. The study also specifically analyzed the Pfizer boosters under the current conditions regarding SARS-CoV-2. So again, these are things that can change over time and also may look different with different vaccines. Also, we know that for a subset of the population, such as those over 65, as well as those with immune compromise, the recommendation has been for a twice yearly vaccine. So this would need to be looked at a little bit differently. For these folks, the timing actually may be a little bit less important or less consequential because they're getting much better coverage by being vaccinated every 6 months. So again, with this optimizing the timing, we are looking at a 3 to 5 times improvement in the yearly protection provided if you compare the optimal date with the less optimal date. So this is definitely something to keep in mind. I also want to point out that CDC is currently recommending that if you get a breakthrough infection that you delay your booster up to 3 months. But based on this study and based on this analysis, I think it's worth rethinking this. So 3 months might be appropriate sometimes, but not all the time. And this graph, I think, is a very creative way to look at this, maybe a little bit difficult to take in, so I'll do my best to walk us through it. I also linked an article from Yale School of Medicine in the post where this graphic is included, and the graphic is credited to Haley Hasler. Hopefully I got their name correct, at Townsend Lab. So taking a look here in the inner circle there, you can see that the months of the year are listed. And if you take a look at September, mid-September, you'll see that this is the optimal COVID booster date as we just discussed. And again, this representation is for New York. Now, what the rings around the outside are attempting to show is that if you get an infection at these different times of year, how it pushes back the optimal booster date. So everywhere that you see a little coronavirus in that outside ring, you can see where your new optimal COVID dose should happen. So for example, if you get an infection anywhere between mid-October through April, your optimal COVID booster date remains in mid-September. But if you get a breakthrough infection in mid-May, so if you look at May, you see the little COVID symbol outside of May, and you follow that ring all the way around, then you can see that you are better off delaying your booster until November. If you get infected in mid-June, then you should delay your booster until early December. If you got infected in mid-July, then you should postpone till late January. And if you got infected last month, mid-August, your optimal booster timing is mid-February. And if you were to get infected like now, like early September, then the optimal booster timing becomes mid-March. So this is one analysis, it's one study. It's a lot more nuanced and a little bit more complicated than the current CDC recommendations, but it is based on a lot of different modeling of antibodies and also geographic conditions that may change over time, but it is data driven and informed by quite a bit of analysis. And for that reason, I certainly think that this is worth considering. So in addition to getting that COVID vaccine at the optimal time, remember gathering outdoors is almost always safer than indoors. But even indoors, you can really improve the situation by opening up some windows, improve the ventilation, turn on your HVAC system and or HEPA filtration units within the space. Also use a high quality filtration mask if you're mixing indoors, especially where there's poor ventilation and in crowded high traffic areas. And try to avoid infection and reinfection. We know that there is a cumulative nature to the effects of COVID, as well as increased risk of long COVID. And that risk is with each infection. And if you don't feel well, please test to rule out COVID. Want to do this as soon as possible, as soon as you have any symptoms, and in particularly if you're someone who should be treated for COVID, get treated. There's a small window of time to really reduce that virus replication and prevent going into a more severe case. And if you don't have a primary care provider, please get one. Know how to reach them before you need them. And again, if you're someone who should be treated, then having a treatment plan ahead of time is certainly helpful, because trying to figure it out when you don't feel well is definitely not ideal. And remember to eat a balanced diet and stay well hydrated. Avoid those simple sugars and processed foods. And quit smoking, reduce alcohol consumption. If you don't feel well, please rest and recover. Otherwise, try to get some regular physical activity, get outdoors, get some fresh air, manage those stress levels, and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you next Tuesday at 10 a.m.